Thank you, Mark. It's a pleasure to be in London. Welcome. And in the Olympic spirit, bonjour, good morning. Mark has emphasized that health is arguably the last major global industry not to be transformed by information science. I think Julie has given a terrific presentation to demonstrate the value that real-time analytics can deliver in terms of improving clinical quality and clinical information. Now, I'm going to spend a little time trying to convince you that with a unified data model, that same information can translate into immense value for research and economic growth. And I thought I was allowed 58 minutes like Bradley Wiggins, actually, Mark. But I'll rattle through it. 58 seconds. Thanks for that. Right. So I'm going to take less than 10 minutes. Current challenges. Secondly, how across the United Kingdom we are calibrating our system to be a world leader in translational medicine and stratified medicine. Thirdly, that information science is a catalyst for a lot of that change. I think case studies are so important because they bring things to life. And lastly, the chronic disease challenge is an international challenge that faces us all. Can we collaborate across international boundaries to make things happen? So I won't dwell on the chronic disease challenge because the Prime Minister's summit yesterday emphasized the challenge of communicable disease. So you know that it's the major cause of mortality internationally. 42% of us of all ages live with a chronic disease, many with 2, 3, 4, or 5 chronic diseases. In my own domain, diabetes, by the year 2030, 500 million people on the planet will have type 2 diabetes, with 100 million of those living in China, with the knock-on effects in terms of cardiovascular disease, stroke, blindness, and renal failure. It's not only a healthcare challenge, it knocks onto the GDP issues of countries, and the World Economic Forum estimates that chronic disease will cost us $47 trillion over the next 20 years. So we urgently need to address the efficiency and strip out the waste, duplication, and harm in our health systems. And our thesis is shown on this slide. We think that with great information science, we can bridge between excellence in life sciences through the final common path of translational medicine, clinical trials, through to world-class patient care. And we're going to use information science to do it. So our manifesto, and I would argue if I had lunch with all of you individually, you would say that the gap in your healthcare environment is that we lack a full longitudinal view of the patient because the data are distributed in silos across healthcare systems. So our approach in the United Kingdom is to use a unique patient identifier to sort out the governance so that it's proportionate, to protect privacy, but allow data sharing and not allow governance and privacy issues to conspire against quality care and research. Bring high-performance computing into the heart of healthcare as a core business so that we can create a cross-health system domain of information which provides information services for clinicians, patients, and researchers, and to do this on a UK basis. And if Peter Knight had been here, he'd have talked to you about CPRD, which is our exemplar program of doing this across the entire UK, and I'll touch on UK Biobank later. So one or two brief case studies to show where we are in that journey in terms of quality of care, trials, evaluation of policy, stratified medicine, and international collaboration. An exemplar program is the National Diabetes Clinical Information System we have in Scotland. We have 251,004 people with diabetes in Scotland today because I checked this morning, because we have a web-based clinical information system that spans primary, secondary, tertiary care, going into every hospital, every laboratory, every general practice with patient access as well. Shown schematically here, using the valued data within health systems, bringing them together in a unified way, whether it's in laboratories, pharmacies, retinal screening, etc. Does that add value? Yes, it does. Since 2007, on a nationwide basis, we've measured key process measures on every patient in 95% of cases. And what we've published on is that that maps into an improvement in outcomes, which are important to patients. Reduction in amputation by 40%, which were in press on a national scale, reduction in blindness by 40%. So good integrated use of information can actually improve quality. But there's a secondary benefit, and that's in the research environment. One can use that same platform to run clinical trials. So the clinical system supports research, and every patient in Scotland is invited to join a research register. Can their data be used for prospective eligibility checking for clinical trials? And it's generated a lot of inward investment. And in terms of the data, the number of studies has gone up by 50% since 2007. The number of patients in randomized trials has gone up by 300%, and we've been the top global recruiter in 3 international studies. So using the same data to drive trial performance. What about trial follow-up? This is a famous study, the WASCOP study, pravastatin versus placebo. The boxed area on the left side of the slide shows the BMS-funded study, £30 million. Blue line, pravastatin, showed benefit over placebo. At the end of most studies, people are sent home, back into the system. But because one can record link to hospital admissions, mortality, coronary vascular events based on their hospital number, 10 years later, we could see what had happened to patients, and the benefit of statins persisted for an extra 15 years. But the key was that second study, published in the New England Journal, cost £30,000, because the data are in-house. What about evidence-based policy? The smoking ban. Many of our countries have implemented a smoking ban in public places. Did it have any impact? Using routine data on 5.2 million people, we're able to show the smoking ban reduced hospital admissions by 17%. 67% of that reduction was in non-smokers, showing the benefit to passive smokers. What about childhood asthma? Even in Scotland, 5-year-olds don't smoke. We showed that before the ban, this natural increase in autoimmunity, after the ban, an 18% reduction. So using data that we have in-house to answer important public health questions. And lastly, as we move towards a world of stratified medicine, the molecular characterization of individual patients now was not foreseeable 20 years ago. We were in the era of a genome being available for $1,000. The Human Genome Project, Mark, was $750 million to do one genome. So through great prescient foresight of NIHR, MRC, Wellcome Trust, and others, I estimate about 1 million people in the UK signed up for genetic analyses, and we're using those data and linking them to the routine health data. A quick example in pharmacogenetics, because we have exposure from the electronic health record, we've got genetics from consented data, and we've got outcome, and one can look to see how new biology from existing drugs. This drug is metformin, and it's demonstrated a fascinating link between 2 chronic diseases, metformin and cancer. Can this stimulate economic growth across the UK? There's some great examples here, a few of ours, working with CROs, big pharma, because this environment, we hope, will facilitate industry to run smarter studies and make difficult decisions earlier in the drug development cycle. Another example is how this can create businesses. An example is Iridia, a joint NHS-owned company with the university, where we're taking this model using cloud-based computing to address chronic disease challenges globally. The example I'll show you is in Kuwait. The national dress of the Scots isn't in white, I should say. But we're taking a package of informatics, chronic disease management, education, 120 MSc and PhD students, clinical skills, and working collaboratively with the Ministry of Health, the Dasman Institute in Kuwait, to implement this chronic disease management model to drive efficiency and quality in healthcare, led by Dr. Kazem Behbahani, who was the previous Deputy Secretary General of the World Health Organization. So I think this model is scalable, and it's urgent. In Kuwait, for example, almost 25% of the entire population have diabetes. So there's an urgent need to look at these issues. And here's one or two screenshots of the Kuwait Health Network, a bit like the UK Health Network. So to summarize, Mark, on my 9th minute, opportunities for health informatics and analytics using the data in a smart well to address current healthcare challenges is definitely within our grasp, despite the adverse economic climate. We need to bring information and computer science into healthcare boardrooms and see it as core business. I think that collaborative open innovation partnerships between NHS, industry and academia are the vehicle to add real value in this space for better patient care and economic growth. And I think that this is a global challenge that faces us all, and there are real opportunities for us to drive forward in terms of international collaboration to address this chronic disease challenge. So thank you very much for listening.